Good afternoon and welcome to today's IAC webinar, Fetal Echocardiography, Protocol and Technique. My name is Kelly Baer and I am the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar, please note the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, on the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASE CEU credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC, SOAP, and ASE. And now I would like to introduce today's guest presenter, Michela Perez. Michela is a clinical ultrasound educator specializing in high-risk obstetrics and fetal echocardiography at Scripps Health Division of Maternal Fetal Medicine in San Diego, California. She has over 16 years of experience in academic medicine at the University of California, San Diego Medical Center, serving as a clinical instructor and faculty lecturer for departments of radiology, obstetrics and gynecology, and reproductive sciences at UC San Diego School of Medicine. She's a true expert in the field, and we are happy to have her with us today. And with that said, I will now turn this webinar over to today's speaker, Michela Perez. Michela?
Thank you. Thank you so much. I wanted to thank the IAC for inviting me to speak on fetal echocardiography and also share my knowledge in terms of protocol and technique. So my only disclosure is I do lecture for GE Healthcare. So in the next hour, we're going to review the standard sonographic views for fetal echocardiography according to the AIOM guidelines. Also recognize the sonographic features of the common congenital heart disease encountered in practice, and discuss fetal heart image optimization tips and a few pearls to take home. So the AIOM practice parameter for the performance of fetal echocardiography was developed in collaboration with these organizations as you see listed. So this is to provide the medical ultrasound community with recommendations for the performance and recording of high quality fetal echo exams. So before we move forward with the imaging guidelines, let's just review the common fetal and maternal conditions associated with an increased risk of congenital heart disease. However, to note, most congenital heart disease are not associated with any known risk factors, but often suspected at the time of an anatomic ultrasound survey. So with fetal factors, fetal echo is indicated if there's a suspected cardiac structure abnormality, suspected abnormality in cardiac function, high drops, persistent fetal tachycardia. This is with a fetal heart rate of greater than 180 beats per minute, persistent fetal bradycardia with a fetal heart rate of less than 120 beats per minute, or even a suspected heart block, and frequency episodes of a persistently irregular cardiac rhythm. Major fetal extracardiac anomalies and a nuchal translucency of 3.5 millimeters or greater, or above the 99th percentile for gestational age. Chromosome abnormalities by invasive genetic testing or cell-free DNA screening, and monochorionic twinning. Now, fetal echo is reasonable or may be considered with findings of systemic venous anomalies, such as persistent right umbilical vein, left SVC, and even absent ductus venosus, or greater than normal nuchal translucency measurement between 3.0 to 3.4 millimeters. Now, maternal or familial disease or maternal environmental exposure, fetal echo is indicated with pre-gestational diabetes, regardless of hemoglobin A1C levels, gestational diabetes diagnosed in the first or early second trimester, IVF including ICSI, maternal phenylketonuria, autoimmune disease such as anti-SSA, with a prior affected fetus, and first degree relative of a fetus with CHD, such as parents, siblings, or prior pregnancy, and first or second degree relative with disease of Mendelian inheritance and a history of childhood cardiac manifestations, retinoid exposure, and first trimester rubella infection. Now, fetal echo is reasonable or may be considered under maternal factors with teratogen exposure, antihypertensive medication, autoimmune disease, SSA antibodies with a prior affected fetus, or second degree relative of a fetus with congenital heart disease. As for these specific indications, as we see here, and also isolated conditions, there is minimal increased risk for congenital heart disease above the general population. So the detail 76811 exam may be appropriate, which includes, an evaluation of the fetal heart. So fetal echo is performed only when there is an abnormality detected. So this is for gestational diabetes, warfarin exposure, alcohol exposure, echogenic focus in the heart, maternal fever or viral infection, and isolated congenital heart disease, and a relative further removed from second degree to the fetus. And also goes for this as well. Fetal echo is performed if an abnormality is detected on a 76811 exam. We have obesity with a BMI of greater than 30, selective serotonin reuptake inhibitor antidepressant exposure, non-cardiac soft marker for aneuploidy in the absence of karyotype information, abnormal maternal serum analytes, and also isolated single umbilical artery. So fetal echocardiography is commonly performed between 18 and 22 weeks gestational age, although some cardiac structures may be better visualized before or even after this period. And also with fetuses with severe complex congenital heart disease, we could actually see these in the first trimester. So now moving on to the imaging guidelines. What is required in the updated fetal echo guidelines? So here you could see just a chart of the required imaging. We have, 2D in grayscale imaging. We have the 4-chamber to include the pulmonary veins. So the areas that are actually highlighted in yellow depict what is currently updated in the guidelines. We have the short axis views at the level of the 4-chamber for ventricles, low for ventricles, heart rate and rhythm assessment. We also include the left ventricular outflow tract, right ventricular outflow tract, short axis view high to include the outflows, branch pulmonary artery and bifurcation, 3 vessel views, including the main pulmonary with artery bifurcation, and also the 3 vessel and trachea view, ductal and aortic arch, and the superior and inferior vena cava. For color Doppler, we now have the pulmonary veins, at least 1 right and 1 left, atrioventricular valves, atrial septum and foramen ovale. We also have the right and left semilunar valves, and also including the 3 vessel trachea views, ductal and aortic arch, and superior vena cava. And as well, also the ductus venosus. As for pulse wave Doppler, we have the right and left AV valves, pulmonary veins, at least 2, 1 right vein and 1 left vein, a right and left semilunar valves. And as for the rest, those are all, clinically relevant or needed. And for cardiac biometry, Z-scores are not currently part of the guidelines. They're not required, although we do measure tricuspid and mitral valve annulus and diastole with absolute size with comparison of left to right-sided valves, and aortic and pulmonary valve annulus in systole. And the rest, as for 3 vessels and the arches, that would be, clinically indicated. Now, additional fetal cardiac biometry is performed if an abnormality is suspected. In case, there is right and left ventricular lengths. We have the aortic arch and isthmus diameter measurements from the sagittal arch view or 3 vessel trachea view. Main pulmonary artery, along with the ductus arteriosus measurements, and diastolic ventricular diameters, just inferior to the AV valves, cardiothoracic ratio, or if clinically relevant, we have the systolic ventricular dimensions, short and long axis views, transverse atrial dimensions, and branch pulmonary artery dimensions. And cardiac function assessment is done if clinically relevant, as well as complementary imaging strategies to include 3D and 4D, tissue and continuous wave Doppler, and other additional functional assessments. Now we have also specific documentation, which requires motion video clips. So in addition to still frames, these are needed for documentation. Now, if there's any, suspected structural or functional cardiac abnormalities, additional clips are needed. So the required clips include an axial sweep from the abdomen to the 3-vessel trachea view. We have the 4-chamber with 2D and color Doppler, left ventricular outflow tract, that applies to and also to the right ventricular outflow tract, 3-vessel and trachea view, and sagittal, aortic, and ductal arches, all with color and also in grayscale imaging. So these are the required motion video clips. So the fetal echocardiogram is a detailed evaluation of the cardiac structure and function. So of course, the assessment, involves sequential segmental analysis. So starting with initial assessment, determining fetal right and left orientation. So this will be part of your visceral and abdominal situs. And also assessment of the atrial relationship situs, as well as the atrioventricular junctions, ventricular relationship with the ventricular arterial junctions, and also great arterial relationships. So this is, pretty much just for a sequential segmental analysis of the 4 basic areas. And we measure fetal biometry prior to evaluating the heart, and this is just to confirm gestational age and Z-score correlation. Again, Z-score is not required part of the guidelines, but is also an option. So moving on to my favorite part. So with fetal echocardiography, these are the representative scan planes for fetal echo. So here we have the 4-chamber view, as you see down below, left ventricular outflow tract. We have the RVOT view, 3-vessel view with main pulmonary artery bifurcation, 3-vessel view with ductal arch, the 3 vessels, and trachea view. So the initial assessment should always start with fetal situs and also determine fetal left and right orientation. And here we're actually including the 4-chamber, as you can see, starting from the abdomen all the way to the 4-chamber and up to the 3-vessel trachea view. So here you could actually see that the stomach is imaged on the left side of the abdomen. Here we're also able to appreciate the portal sinus with an L shape to the right. And also, if you notice, you see the descending aorta is posterior to the left and the IVC anterior to the right. So very careful attention to these specific structures, as any displacement or abnormal location may be suspicious for heterotaxy. And by taking an axial sweep from the abdomen to the 4-chamber view to the 3 vessels and trachea, here you can see a nice 4-chamber view with apex of the heart pointing towards the left side of the fetal chest, and this confirms your fetal situs. So the 4-chamber view, as you can see here, includes the pulmonary veins, is a key scanning plane. So here you can actually see 3 different, angle of installations or angle acquisitions of the 4-chamber, and clear enough, the pulmonary veins in grayscale. So at least 2. So of course, this helps a lot with, the advent of high resolution transducers and also proper image optimization. So this is a required view and clip. So when assessing for position and access at the level of the heart, you want to draw a line down the middle, traversing through the right ventricle. So the majority of heart is on the left side, apex leftward with symmetric lungs, axis leftward, and 45 degrees plus or minus 20 degrees. And the heart should occupy at least a third of the chest, and this is assessed as surface area. And in circumference, it is about 1/3 to 1/2 of the thoracic cavity in the transverse view. Now, both of these values remain constant throughout gestational age. So when assessing for 4-chamber symmetry, you want to make sure that the right and the left side of the heart are symmetric. So here we have the right ventricle, right atria, and the left ventricle and the left atria. Now, at times during the late 3rd trimester, the right ventricle may appear slightly enlarged compared to the left ventricle. So this can be a marker for like coarctation or other cardiac abnormalities. But on the other hand, this could also be, normal, as it could be a normal variant of 3rd trimester disproportion. So what you could do is, if you have any suspicion for any type of asymmetry with the chambers, you want to assess the chambers in different views, which can help in confirming chamber disproportion. So again, you want to utilize different scan planes or scan angles when assessing for symmetry. So when looking at the heart, you want to make sure that there's absence of pericardial fusion and also pleural effusion. And when assessing the heart, it has to be in a regular danceable cardiac rhythm. Now, sometimes, you can see a little bit of fluid surrounding the heart, and that could be abnormal. And especially with these high resolution probes, you think pretty much there's, fluid surrounding everything, within the fetus, like structures tend to be darker and, or even brighter. So if you're unsure if the hypoechoic space you see here is pericardium versus pericardial fusion, all you need to do is turn on your color Dopplers you could see here. And since pleural fusion is moving fluid, it will fill with color. So this is a pericardial effusion. Now here's an example of a questionable pericardial effusion, and this is pretty much just due to the anechoic area that we see there right by the heart. But when we turn on color Doppler, it does not light up. So there's no effusion there, but normal heart tissue. So turn your color on to confirm for any pericardial effusion. So let's take a closer look at the specific structures of the forechamber. So here we have the right ventricle, which is located anteriorly. We have the moderator band, which is one of the morphologic characteristics of the right ventricle, the tricuspid valve. We also have the right atrium, which is anterior to the left atrium. And also just to note, the tricuspid valve inserts more apically in comparison to the mitral valve. Now looking at the left side of the heart, we have the left ventricle, which is posterior to the right ventricle. We have the foramen ovale, which flaps from right to left, as you can see here. We also have the pulmonary veins, which they're seen as slit-like openings in the posterior wall of the left atrium. And also the descending aorta, which should be the only vessel behind the left atrium and no other vessel in between. Now, looking at valve morphology, the tricuspid valve is, as I mentioned, more slightly apically offset than the mitral valve. So this is very important to assess, as this can represent an anatomic feature that is typically absent in atrial ventricular septal defects. When measuring when assessing for AV valve measurements, you want to, when evaluating the valves, AV valves open symmetrically, and you have to remember these valves are thin, delicate leaflets. So opening symmetrically, and you want to measure the tricuspid valve and mitral valve in diastole. You want to place the calipers at the hinge points of the valve. Okay, so looking at this here, this case 1, suspected ventricular septal defect. But looking at this first image, we can see that when the patient was referred to us, we're like, okay, maybe this heart, sorry, I kind of gave away the answers there, but this heart here, just looking at the forechamber, it might look okay. There's the access seems just right. There seems like there's symmetry. But once we, scanning the patient and we have a nice apical insonation in which we're able to assess the valves, we notice that there's linear insertion of the valves. And clearly this is abnormal. But as you can see in this clip here, you can see a large atrial and ventricular septal defect at the region of the AV valves. So this ended up being consistent with, sorry, there I gave away my answer again. This ended up being consistent with an atrial ventricular septal defect. And here you could see the characteristic classic features of AVSD. You can see a hole in the heart, and with color Doppler, just confirms a single channel of blood entering the ventricles over a common AV valve. So again, utilizing just different scanning planes and angles to assess any specific structure is key to identifying certain defects. When we utilize color Doppler to assess the mitral valve and tricuspid valve inflow. So you want to do this in an apical forechamber view, since your angle of insonation is parallel to the direction of blood flow. So again, if you notice that my color box is pretty much tight around my structures, and this is just mainly to increase the frame rate, which is ideal for detail resolution. You want a higher frame rate with good detail resolution. Scale should be set to high. So this is a PRF anywhere, I would say, greater than 60 to 80 centimeters. So sometimes this can vary because all of this is pretty much dependent on maternal body habitus and also fetal position. And flow should be from the atria to the ventricles. And when assessing with pulse wave Doppler, you want to place the sample gate just distal to the AV valve in the ventricle. Normal waveforms is a biphasic waveform, as we see here. We had E wave, which represents early diastole, A wave late diastole, and the atrial kick. And the E wave velocity should be less than A wave velocity in the fetus. So when looking at the pulmonary veins, as I expressed earlier, here we're able to easily identify the pulmonary veins now on a 4-chamber view. And this is just showing we're able to see it at 18 weeks, 25 weeks, and even 34 weeks. And this is, with the help of, the advent of high resolution transducers and also, improving your optimization techniques. You notice that you can see the slit-like openings in the posterior wall of the left atrium. So it's very important to visualize at least one pulmonary vein on each side in grayscale, especially prior to turning on color. And I just thought, this was just a helpful diagram of showing the location, of the pulmonary veins, pretty much when you angle your transducer towards the left atrial posterior wall, and you could actually see it really nicely here. And this is just a corresponding ultrasound image to this diagram. When assessing pulmonary veins with color Doppler, technique is key to seeing these little small structures. Again, you want to have your color box to small, and this is just to increase your high frame rate. I would say less than 30 centimeters per second. And also you want to assess the direction of flow into the left atrium. And, when in doubt, we use pulse Doppler just to confirm the flow we are actually seeing is a pulmonary vein. And normal Doppler pattern for a pulmonary vein is forward flow, triphasic waveform. As you can see here, the S wave, systole is the first component, then D wave, early diastole, and the lowest component is the A wave, which is the atrial kick and late diastole. And as part of the new guidelines, we want to pulse wave Doppler at least one on each side, one inferior and one superior. Case number 2, normal or abnormal. So we have image A, a 4-chamber heart in apical view, and image B, 4-chamber heart as well. So I'll give you a second just to kind of think and look and see just by looking at this 4-chamber view. So, well, if you guys are pretty much sharper than I am, here we have B, which is a normal 4-chamber view, and A, which is abnormal. So here, as you can clearly see, looking at the pulmonary veins, you can see with the normal pulmonary veins, you could actually see it in grayscale inserting to the posterior portion of the left atrium. But if you notice the pulmonary veins in A, it doesn't seem to be entering, and it almost has like an abnormal shape, almost like a twig. And here's just a showing with color Doppler, showing the normal comparison to the fetus with TAPVR. It's very important to identify pulmonary veins as with color. As you can see, this is going in the correct direction. So again, this can be very tricky, and it's very helpful to assess pulmonary veins in grayscale prior to turning on color Doppler, and how this could actually be easily missed. So grayscale clues when for total anomalous pulmonary venous return. So it's very important to take a look at the retroatrial space. There's an increased distance between the left atrium and the descending aorta in comparison to, the normal heart. We don't see that increased distance. And if you notice too, you could see what looks like an enlarged right atrium, and this is due to the increased venous pressures, and also a smooth left atrial wall. So we don't see any of those pulmonary veins actually, draining indirectly into that left posterior wall. And also, some has referred to this as the twig sign, because it does pretty much kind of look like a twig, as you could see. And that's due to the confluence of the veins. And there we go, all my animations. And of course, the twig sign. So when moving on to the subcostal view, there's several structures that you could assess as well. Here you could see the trabeculations of the right ventricle. and also the apical insertion of the cord tendon of the tricuspid valve to the right ventricular wall, and the apex of the heart, which are important morphologic characteristics of the right ventricle. We could also see that there is an intact septum, as you know, our beam is perpendicular to our septum. So here, this is the best view to see it. We also notice that the left ventricle is conical in shape. And remember, the left ventricle and the right ventricle make up the apex of the heart. Also, other structures you could see is pretty much the descending aorta, and as well as you could see pulmonary veins also in this view. So when assessing for the foramen ovale, I found it very helpful to find the foramen ovale first with grayscale and then turn on my color Doppler. So for technique, you want to keep your color box small. Again, you know, it's very important to optimize 2D image first before adding color. And you want to set your scale to low, so I'd say less than 30 centimeters per second. And you want to be able to assess, assess the flow across the PFO. It should be from right to left. So here you can see it in grayscale really nicely from right to left, and with color, just pretty much confirms the direction of flow. So as I mentioned earlier, angle of insonation is key. So when evaluating the septum, the subcostal four-chamber view is the best, to assess the interventricular septum. You want to sweep the septum, because remember, septum has depth. So starting from the four-chamber and going all the way up to the outflows. And keep your color box small just to focus on the region of interest, and with a low PRF of less than 30 centimeters per second, mid to low wall motion filter. So what do we see here? So here, as we're looking at this four-chamber heart, here we have what possibly could be a questionable VSD. We don't know, but what is wrong here? Actually, to assess the ventricular septal defects, this is an incorrect angle of insonation. So again, you want to change your angle of insonation, and here you could see that there's truly no ventricular septal defect, but just a hypoechoic dropout with the beam and the interventricular septum. Case 3. So here's a case where they suspected there was a ventricular septal defect. So this came, they did the MFMs did their anatomy scan, and the reports stated a VSD, referred for fetal echo. But what are the things that you notice here that's wrong? First, you notice that the PRF is set to high. So obviously that's incorrect technique for assessing for VSDs. And as well, what else? This is the incorrect angle of insonation for assessing for ventricular septal defects. So lo and behold, patient was referred for a fetal echo. And here we have the correct angle of insonation, which the beam is perpendicular to the septum, and with the correct PRF of 2.4, which is appropriate. So anything less than 30 centimeters per second. And there is ended up being a normal fetal echo. So again, very important when you're utilizing your technique, you want to ask yourself, what is it that you're trying to assess? If you want to assess the valves, the AV valves, then you want to be perpendicular. You want to assess for any offset. If you want to assess the interventricular septum, you want to be perpendicular to the beam. Okay, so now moving on into the outflows. So just going through the normal left ventricular outflow tract anatomy, we have the left ventricle, the ascending aorta, the aortic valve, the interventricular septum, the right ventricle, the left atrium, and the mitral valve. And as mentioned earlier, the ascending aorta, which should be the only vessel behind the left atrium. And when assessing, you want to take a look at the nature of the aorta. Is rising from the left ventricle. Aorta is normal in caliber throughout, and also take a look at the continuity of the wall of the aorta with the mitral valve leaflet, and also continuity of the interventricular septum with the wall of the aorta. And again, it's very important to pay attention to the valves, as valves should move freely and come and go in systole and diastole. And so when assessing, aortic valve measurements, we measure this in systole. So again, paying attention to valves. Remember, valves come and go, and they open and close in systole and diastole. You want to place your calipers at the hinge points of the valve during systole. And with color Doppler, you want your scale should be set to high with a PRF of anywhere greater than 60 to 80 centimeters. Flow should be from the left ventricle to the aorta. It's very important to optimize your Doppler angle, especially when assessing for a pulse wave Doppler. And Doppler gate is placed just distal to the valve for peak systolic velocity. And again, normal flow is smooth laminar flow. So case number 4, is this normal or abnormal? So looking at these color flows, we're looking at the left ventricular outflow tract. We know the normal flow of B, smooth laminar flow. But if you notice in A, as we have the color there, we notice that there's a little bit of aliasing or some type of flow disturbance. So this should, immediately, once you turn on color, this should immediately raise red flags. So A, ended up being abnormal, as you could see, in comparison to normal. So this ended up being a fetus with critical aortic stenosis. So as you could see, color is also as helpful as grayscale, but grayscale is just as important in color. So you can see with grayscale imaging, you notice that there's post-stenotic dilation. And also, if you're paying attention to the valve leaflets are very, it's not completely disappearing within the cycle. And just with confirmation, you can see how the color Doppler is normal. And this was consistent with critical aortic stenosis. And with peak systolic velocities, which is 148 centimeters per second pulse wave. And so it's very important, again, that, when you see color, using light color, you want to see smooth laminar flow. And again, correct Doppler of angle of insonation as well. So it's speaking of angle of insonation and angle of acquisition, I feel it is very important, to assess, fetal heart structures in different views. Because in an ideal world or in a perfect world, we know that, we can't always get the perfect views. So again, these are just different angle of insonations. So you want to be familiar with non-traditional views. So here's a sweep from the subcostal view. This happens to be one of my favorite views. And here you're able to assess, many structures. So here we're able to assess the interventricular septum, specifically the paramembranous area. We're able to also assess for any aortic override. And also we're able to see the aortic valve. And with color Doppler, again, you want to assess the flow across the aortic valve. You should utilize a high PRF of greater than 60 to 80 centimeters per second, or you could also assess the septum. But in this case, you would actually have to drop your technique to a low PRF of about less than 30 centimeters per second. Again, normal flow is smooth laminar flow. Okay, so looking at these two clips, is this normal or abnormal? So here you could see that B is normal. You could see a nice intact ventricular septum, continuity with the wall of the aorta to the interventricular septum. But you notice in A, this is abnormal. So here we see defect along the interventricular septum, and this is consistent with an overriding aorta with a ventricular septal defect. So in moving on to the right ventricular outflow tract, so here we have your right ventricle, tricuspid valve, right atrium, pulmonic valve, aorta, pulmonary artery, ductus arteriosus, also the right pulmonary artery. You can't see the left pulmonary artery, is not seen in this view. But here you could actually see it. So when assessing the pulmonary artery, we want to make sure that it is greater, if not equal to the aorta. And again, when assessing the valves of the pulmonic valve, they move freely and they come and go in systole and diastole. So again, very important to pay attention to the valves. And here in this view, we're able to appreciate the main pulmonary artery branching to include the left pulmonary artery and the right pulmonary artery. So this is, again, another important anatomic characteristic that differentiates it from the ascending aorta. So again, PA should never be smaller than the aorta. When measuring the pulmonary valve measurements, this would be measured in systole This is also part of the required new practice parameters. Again, when assessing the valves come and go, and you want to place your calipers at the hinge points of the valve during systole. And assessing for color flow through the pulmonic valve, normal flow is smooth laminar flow. And here scale should be set to high with a PRF of at least greater than 60 centimeters to 80 centimeters per second. And flow should be from the right ventricle to the pulmonary artery. Again, very important to optimize your Doppler angle. And you want to place the Doppler gate just place distal to the valve for peak systolic velocity. Case number 5. So is this normal or abnormal? So what is it that you notice here? This is almost like a level of the 3-vessel view. So here we could see that looking at this, we can see the pulmonary artery. So B, we have the normal pulmonary artery, which is equal, if not slightly greater than the aorta. But in image A, this is abnormal. So here you can see that the pulmonary artery dimensions is smaller than the aorta. So this fetus was consistent with tetralogy of Fallot. Again, it's very important to pay attention to dimensions, and the pulmonary artery should never be smaller than the aorta. So here's another great sweep. This is crossing of the great vessels. So this is starting in the subcostal view and going into the long axis right ventricular outflow tract. So in this sweep technique, you can verify the crossing of the great vessels at the level of the valve, and you can also visualize the valves clearly and moving freely. And if you notice too with color Doppler, it also confirms, the crossing just by the different color directions or the angle of inclination of the arteries to the beam. So this is normal crossing of the great vessels. So now moving into the 3-vessel trachea views. So why the 3-vessel trachea view? So here we're able to determine the course and the connection of the aortic and ductal arches. This also helps in identifying ductal dependent lesions. Also, we're able to identify the relationship of the arches to the trachea and also size of the vessels relative to each other. So we're able to determine any discrepant abnormalities. So most of the time, the 3-vessel trachea view is abnormal in most congenital heart disease involving the outflow tracts. And you want to take note that this does not replace the left ventricular outflow tract or the RVOT. This is pretty much in addition to the outflow tracts. And with addition to color Doppler, we're able to determine the direction of flow of the vessels. Okay, so just going through the normal anatomic structures, we see at the level of the 3-vessel view, the ductal arch view. Here we have the main pulmonary artery, which moves on to the ductus arteriosus, continues to the ductus, and we have the ascending aorta, and here we have the superior vena cava, and as well the trachea. So again, very important to note where the vessels are in relation to the trachea. So these vessels should be oriented from left to right, anterior to posterior, with an oblique orientation. So largest to smallest, you have the PA, if larger, if not slightly equal to the aorta, and the SVC being the smallest. And with the 3-vessel view, main pulmonary bifurcation, so just a few millimeters below from the 3-vessel ductal arch view, we're actually able to identify also the main pulmonary artery branches, such as the left pulmonary artery that we see here and the right pulmonary artery. Now, a few millimeters above the 3-vessel trachea view, here we're able to see the 3-vessel trachea view. So here we have the orientation of the aorta and the ductal arches being to the left of the trachea. So this is what defines them both as a left ductal arch and left ductal arch, and giving this nice V configuration. And so this is how you're able to pretty much detect any type of arch abnormalities. And also we're able to see the SVC in this view, and also the thymus. So any absence or hypoplastic thymus is a marker for congenital heart disease, specifically deletion 22q. And when assessing the 3 vessel views with color Doppler, there's anterior posterior flow in both ductal and aortic arches. And this should be to the left of the trachea and towards the spine, giving it this V-shaped configuration, as you see here as well. And reversal of flow in either vessels is abnormal. So when utilizing color technique, you want to utilize a high PRF of at least greater than 60 centimeters per second and a small color box to increase that frame rate, especially when turning on color. And with a very simple sweep, so starting from the 4 chamber and angling up towards the fetal head, and even all the way up to the 3 vessel trachea view. So in this 3-second sweep, we're able to rule out major congenital heart defects, and it's even more so with color Doppler. And here's just a checklist that you could see in my next slide here of the 3 vessel view, 3 vessel trachea view. You want to ask yourself when assessing these specific areas, is there a normal number of vessels? So again, look for 3. Normal shape of the vessels. The PA should be greater, if not equal to the aorta. Also, again, assessing in size. Normal arch-sidedness. So the pulmonary artery and the aortic arches should be left to the trachea. Also, normal direction of flow. And also presence of a thymus. So what to look for, again, if there's any abnormal vessel course or alignment, abnormal vessel number, even abnormal vessel size, and abnormal color Doppler pattern. So typically, most of these findings often present together. So case 6. So here, you're just looking at this 3 vessel view, we do see what you see an additional vessel. And this is pretty much the 4th vessel located left to the pulmonary artery. So this ended up being consistent with a persistent left SVC. And here you can see that the 4 chamber, demonstrates a cross-sectional view of the left SVC at the border of the left atrium. You could also appreciate the dilated coronary sinus in the region of the mitral valve. So it's very, important to be aware of the anatomic course of the coronary sinus because this can lead to a huge pitfall. So here you could see in this up image to the upper right, you can see at the level of the dilated coronary sinus. As we move further back, you can actually see the coronary sinus in its entirety towards the posterior portion of the heart. This can actually resemble a pitfall may resemble also an atrioventricular septal defect. And just by looking at this, you can see that you're losing your, you see what we have the linear insertion of the AV valves. And, this is usually a typical finding with AVSD defects as well. So again, this is a pitfall. So now moving on to the short and long axis views. So in assessing the short axis views and low, here we're able to assess for any, evaluate ventricular function and also taking a look at the septum. You can also identify the ventricles by the septal leaf attachments. So mitral valve has no septal attachments and the tricuspid valve has septal attachments. And as you continue to sweep towards the apex, you're able to see the left ventricle free wall papillary muscles. So that's also one of the ways to kind of identifying, in cases that you have a patient that for suspected heterotaxy, where all, the vessels or the chambers are switched. One of the things to take a look at is taking a look at these ventricle characteristics, such as this as well. So left ventricle has free wall papillary muscles. And with color Doppler, you want to see through the short axis view from the apex to the great vessels and to assess for any ventricular septal defects. Again, technique is key for being able to identify any specific defects with color. You want to keep your color box small, just kind of tight around the specific structure you're assessing. And this is to increase the frame rate and also keep your scale to low. So I'd say less than 30 centimeters per second. So moving on to the long axis view in fetal echocardiography. So here we see the normal aortic arch components, such as the right atrium, left atrium, the ascending aorta, descending aorta, right pulmonary artery, the innominate vein, you can see here, and the thymus gland, and the distal end of the ductus arteriosus, which we'd actually not seen in this view. So we include these in 2D color Doppler and also part of the required motion video clips. It's very important to know or be familiar with the head and neck vessels. Here we have the ascending aorta. We also have the innominate aorta, which is the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. So it's very important to be aware of these specific structures. This is what differentiates from the ductal arch are the head and neck vessels. We also know the aortic isthmus and also the area of the ductus arteriosus. Now with color, with the aortic arch, it has a candy cane appearance. The aortic arch originates from the middle of the heart, and color flow should be prograde across the arch and should be smooth and laminar in flow. So again, if you notice too, my box is pretty much kept tight around the specific structure. We utilize a high PRF, so anywhere again greater than 60 to 80 centimeters per second. Sometimes I utilize a high definition Doppler just to kind of see the head and neck vessels, but I utilize color a lot just to determine if there's any type of aliasing going within the arch. So again, technique is key when evaluating these arches. So with the ductal arch, here you're able to see the left atrium, right atrium. You're also able to see the tricuspid valve, right ventricle, pulmonary valve, main pulmonary artery, right pulmonary artery, left pulmonary artery, ductus arteriosus, and the descending aorta. I like this view because if you notice here, you can see the ductus arteriosus, and as well you can see a little bit of the aortic arch slightly coming in. It's again very important to differentiate these two, and also to recognize how close they are in terms of in scanning the fetus, how you could easily sometimes confuse the two or confuse this for an aortic arch rather than a ductal arch, especially in cases where there's like a hypoplastic transverse arch. So differentiating the two is key. And we're looking at the ductal arch. It arises from the right ventricle, which is the most anterior chamber. It gives this hockey stick shape and also connects to the descending aorta. Color Doppler flow should be from right to left flow. And you want to see flow from the right to left, shunting blood away from the lungs. And ductus arteriosus should be wide open, as you can see here, when evaluated with color Doppler. Smooth, laminar flow. When assessing the SVC and IVC, we assess this with 2D. 2D, I know color Doppler as well, and also motion video clip. And here you can see the corresponding structures. Here we have the SVC, the right atrium, the IVC. This is the liver, fetal liver. And you can also see the gestation valve in this view. When assessing the bicaval view, you want to make sure that the vena cava sizes should be similar. Now, sometimes you'll notice that there's a little bit of a slightly dilated area, which is the proximal portion. And this is within the IVC, and this is where we have the umbilical and hepatic veins drain. So this may be slightly enlarged, but this is mainly because of these vessels inserting through that area. But you want to look at the vessels throughout, making sure that they're similar in caliber. If you notice one that tends to be slightly enlarged, then these are red flags again. To further assess any specific structures of why there might possibly be some type of overload. And with the bicaval view with color Doppler, here we're able to assess the presence and direction of flow. Again, this helps also in determining or confirming vessel proportions. Directional power Doppler may be helpful. So, but in this case, I'm using color Doppler, and it's because these vessels require like a low flow as well. And with directional power Doppler, it tends to be more sensitive to lower flow velocities. But in this case, I had a really, ideal patient scan, and here you could see a nice, filling of the vena cava. Now, moving on to heart rate and rhythm assessment. So, M-mode or Doppler technique is to include simultaneous assessment of atrial and ventricular rate. So again, optimization is key when taking a look at M-mode, especially with a fetal echo. So you want ideally the 4-chamber view to capture both atrial and ventricular free walls. You want to use your high-res box, which is usually the zoom box that you have available on the ultrasound machines, and the cursor intersects to the ventricular and also a wave or walls. And here you could see, you pretty much see pretty much see the intersection, and here you can see where it shows the left ventricular wall and also a nice interventricular septum and right atrial wall. And here you have your atrial to ventricular wall, just showing 1-to-1 AV conduction. So again, 4-chamber view is the ideal plane to capture atria and ventricular free walls. So when looking at the heart, again, so heart should not squeeze. Heart should squeeze, not rock. It's normal, danceable rhythm. You want to have a normal rate, anywhere between 120 to 160 beats per minute, and 1-to-1 AV conduction. Okay, and last but not the least is ductus venosus. So this is the only required, Doppler in terms of assessing pretty much fetal flow. So the ductus venosus shunts a portion of the left umbilical vein blood flow directly to the IVC. This allows oxygenated blood from the placenta to bypass the liver. And also this can be a predictor for perinatal mortality in preterm IUGR fetuses and fetal cardiac compromise. You could actually see the ductus venosus. So as for Doppler technique, here we have two views, both in the axial view. This is the axial view of the abdomen and also the sagittal view. It helps, with technique, since the ductus venosus is very, very small. You want to drop your PRF to at least less than 30 centimeters per second. And this is to be able to identify the aliasing. And here you could see it in the sagittal view as well, and also in the axial view. And here we just have the normal, quantification across the ductus venosus, displaying the characteristic triphasic waveforms. So S, which is in ventricular systole, D, early diastole, and also A, which is in late diastole, atrial contraction. And I thought this was very helpful, is to include just the fetal echo checklist. There was a lot that we discussed. I'm going to just trying to go through a systematic view, starting with the situs and moving into your 4-chamber, into your outflows, 3-vessel trachea view, short axis, your ductal arches, bicaval view, then moving on to your Doppler assessments, cardiac biometry. So in conclusion, it's very important. You have to know your fetal cardiac anatomy to know what you're really looking at. Also use a systematic approach when evaluating the fetal heart. Evaluate the ventricular septum perpendicular to beam. It's always very important to optimize your angle of inclination. So you also want to think, what am I trying to evaluate? And also pay close attention to the valves. Valves come and go in systole and diastole.
Okay, thank you. At this time, we will begin the Q&A session. From IAC Echo, I'd like to introduce Katie Gibson. She's our Director of Accreditation for IAC Echo. She'll be assisting with the Q&A session today. Katie, would you like to start us off?
I sure would. Thanks, Kelly. And thank you again, Michelle, for presenting that pretty fantastic webinar. The pictures are beautiful. I can't get over how pretty they are. And also thank you to Society of Pediatric Echocardiography and American Society of Echocardiography for sponsoring our webinar today. And so let's start off with some fun questions. So earlier you mentioned a 76-811 exam. Could you tell us what that is? Not sure all of us know what that is.
The 76-811 is basically, it's a code for a specific detailed, it represents the detailed anatomic scan. So you have the 7605, and I'm probably opening more, can of worms here. 76805 is the basic anatomy scan. Now with the 76811, this actually includes additional views, to assess for, the high risk population. So that's the 76811 anatomic scan. And with the 76811, it's pretty, they include pretty much all the majority of the heart views in there. And the only thing is, with fetal echo is just kind of pretty much, assessing, going more further and assessing more with, function of the heart, velocities, as well as measurements as well. So that's the 76811. So 76811 is a detailed fetal anatomic scan.
Thank you for that clarification. That was wonderful. We had a few questions regarding required measurements. One of the questions was, are measurements of the tricuspid and mitral valve annulus required or optional? And just based off of the guidelines.
So the measurements based on the guidelines are required based on the guidelines for cardiac biometry, but I believe Z-scores are not are not currently not required. It's an option.
Gotcha. All right. Thank you for that clarification.
To assess for, pretty much right and left, any possible right and left disproportion as well.
Great. Thank you. We saw a lot of really nice images, and I like how you pointed out that some could be about pericardial fusion, how it could possibly be a normal variant or, artifact, or just we're seeing so much beautifulness with all of our great new transducers. So could you suggest a color scale that would be a good setting when you're checking for pericardial effusion?
So I would say drop your scale low, so I would say anywhere less than 30 centimeters per second. So low scale to take a look and make sure that that's not pericardial effusion. Because obviously if it was moving fluid, then you'd see the flow go around pretty much the heart, the pericardium. So low scale to take a look or to assess for pericardial effusion. Gotcha. So less than 30 centimeters per second.
Okay, great. And do you happen to know if there is a cutoff measurement number for physiological pericardial effusion?
Good question.
That is a good one.
So for maternal fetal medicine, I know this can individualize based on other institutions, but our institution at Scripps, we use anything less than 3 millimeters is considered a physiologic pericardial effusion. Anything beyond that would be pericardial effusion.
Right. Gotcha.
Very number specific. Yeah.
Right. And where can we find all of these new guidelines that you spoke about?
So these new guidelines are available on the AIUM website as well. And I could also include this as part of the PDF handout that people can upload if they wanted to as well. But you can find this on the AIUM website under practice parameters. So these were just released pretty much earlier this year.
Okay, thank you. And is there any document with reference values for the AV valves and the semilunar valves, the annulus? Do we have any reference documents for what's normal based off of gestational age besides these scores?
I don't have any on the top of my head right now.
Okay.
But I know that's a good one. There is a lot of published material out there in regards to Z-scores, right? with according to gestational age as well, and that's what we that's what we use pretty much in our lab to help guide us in terms of what's abnormal versus normal. Right.
We have a few questions. People were asking for some tips on how to get the 3-vessel view. Can you give us a few more pointers on how to get the 3-vessel view, or how to look at the pulmonary artery when trying to rule out tetralogy of flow?
So from the 4-chamber, I would just sweep up to, and you're coming from the 4-chamber, just sweep up to, up to the fetal neck. And from usually when you're able to get the pulmonary, right when you get the right ventricular outflow tract, you angle up slightly and you're able to get the also the aortic arch. So there you have the 3-vessel trachea view. So it's just being axial and angling up towards the fetal head. That's pretty much it. And sometimes, it pretty much, as I mentioned earlier, with the sweep that I had from the 4-chamber through the 3-vessel trachea view, it's actually, pretty simple. So it's something to kind of try and practice and implement too, as well.
That's great. Thank you. All right. We have another good one. Can you comment, or do you have any comments on the SVC aorta Doppler method for ruling out arrhythmia?
So SVC, so I know with some institutions, they actually utilize the SVC, the aorta, in which they're able to capture for, to assess for any type of arrhythmia. So you have to remember, I'm coming from a maternal fetal medicine perspective, and it's something that we usually don't commonly do as well. But I know that some institutions utilize that for the SVC and the aorta, simultaneously Doppling both to assess for fetal rhythm.
Great, thanks. And I think we have time for maybe one more. Let's see. Oh, here's a nice one. I like this question. Can you give us some tips for keeping multiples straight? I think a lot of our users are coming from, a lot of our attendees are not coming from maternal fetal medicine background. They're coming from a pediatric cardiology background. So do you have any tips on how to, scan which one?
Multiples. That's funny. Okay, so with multiples, because we see them often, so so with multiples, of course, depends. Now you ask, depends what type of multiples that you do scan. Obviously with the dichorionic diamniotic twins, they're pretty easy, because they're differentiated by pretty much sacs, and also like you have a thick membrane. So you just pretty much got to stay in one specific area, like maternal right and maternal left. Now you have difficult ones, such as the monochorionic twinnings. It can be very, very challenging. I guess, pretty much what I do is when I start scanning them, I try to just keep my sector angle width narrow to just that fetus, to know that I'm within, because it's very easy to, if you could see both fetuses in the same plane, you could easily just slightly merge onto that, to the next, to the other fetus. So one is, just kind of finding an area, like if it's baby's maternal right, then stick to maternal right.
Right.
And then if it's baby is like maternal left, then I would say stick to maternal left. Not unless you have a fetus, both babies that are moving like crazy, then that's, you would want to pray that baby can actually stay still.
Yes, I think we've all been there. Thank you so much for the great Q&A session.
Thank you.
Okay, great. Thanks again, everyone, and very special thank you to Michela Perez for her presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Fetal Echocardiography, Protocol and Technique. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen, and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.